we're struggling as a field to identify shock, and what do you think of all those things you mentioned? What do you think is the rate limiting step here? Do you think we're not defining it properly, or we're catching it late because of that definition? I'll tell you, I'll speak in my lecture that we are, Navin is on this as well. We have a new consensus document coming up by SCAI and HFSA together with critical care, emergency medicine, and surgery, and nursing as well, on how to define shock and to try to subclassify this to earlier initiation of, early identification of shock, pre-shock, and do you think part of the problem is really that by the time they come to the lab, we really fail to recognize it appropriately and catch these patients early enough?
I think that's clearly one of the factors, and definitions are really essential, and that's something that we in the heart failure community are struggling with in the heart failure preserved ejection fraction population, that we've been studying this as a single large entity, and it's probably some different subgroups. But agreeing on the definitions, I think, are essential. Something that's simple, that's easily identified, and that's associated with adverse prognosis, then helps us not only identify it, but recognize that this is an emergency and this is something we need to react to quickly. So I think that's an important step. These are very sick patients, which doing clinical trials in such sick patients is always challenging as well. So I think that's been another pitfall. And then in the medical arena, as I alluded to, I think the financial incentive for some of the studies isn't there in the same way that it is for devices, where there's more of a financial incentive, partly because they're more expensive. So I think those are, as I see it, some of the biggest obstacles.
Others on the panel, what do you think the rate limiting step here is?
Yeah, I think the problem with shock, most of the time we depend on tools are not readily available in the ER and in a hospital ward. Without deep measurement of the cardiac output, you cannot understand why the patient has low blood pressure. And it could be multitude of reasons, and you could have low blood pressure but still have a good cardiac output. So. And it's kind of moving targets for us, and we still do not have a concept of the hemodynamic deficit, like there are patient and other patients. So I think your work and Navin's work in that field, it's a tremendous, and I think we still have ways to go in that.
Yeah, so I would say that for us, for the next 10, 20 years, shock is the new STEMI. And that's how I would think about it, is that we've developed phenomenal programs for STEMI management, and we've really moved the dial on in-hospital mortality. The difference, of course, is that the adjudicator for STEMI is an EKG. And if only shock came with an EKG, but it doesn't. And so I think the first step is identifying what's going to be the most common, simplest way to identify patients in shock. But then comes all of the structure building around the algorithm for how this should really be treated as a door-to-balloon time, very similarly a door-to-support time. And that's, again, one of the major messages from the CSI program.
Okay, great. So Ajay, take us through all the different devices.
Yeah, so I think that comment leads perfectly into this talk, and I was initially given the task of when to use hemodynamic support and device selection in shock simplified. And I'm going to tell you that I actually don't think that it is that simple. I think you have to be thoughtful about this. Patients are dynamic, and we have to adapt what we do during the course of these cases, and I'll show you some case examples in order to support that. This is a slide from Navin showing you what the spectrum of devices there are out there. Basically, left ventricle, right ventricle, and variety of devices for each. And this is one of the reasons why I don't think it's so simple, because there are different devices, and none of them are good, bad, or otherwise. I completely agree with your slide that you showed. It's just you have to pick the right time for each one. The fundamental principle, though, is we know that as your cardiac power output is lower, your outcome is worse. And the way you can determine this is by looking at the blood pressure and by measuring the cardiac output. And so every single one of us up on the panel is going to tell you repeatedly that you need to do Swan-Ganz catheterizations to figure this out. And you need to do them dynamically and adapt to things in real time. So this is just an example of a 46-year-old gentleman who was ultimately transferred to us, who presented to an outside hospital with what was billed as DKA/honk. And on arrival, blood pressure was 100/60 and the heart rate was 110. He had elevated JBP, crackles, and no murmurs. And I think most people, if you look at this type of patient, we see these patients a lot in every hospital, every ER, every day, and this patient is not a patient you can tell right then what's going to happen with them. The patient can evolve one of two ways. They're either going to get better or they're going to get worse, and in some cases a lot worse. Most people would say this patient's probably not in shock, but we don't know that until we make other measurements. Lactate's 2.3, creatinine's 1.2, blood gas shows some metabolic acidosis, and he's got pulmonary infiltrates on his chest x-ray. So if this patient is acted upon very, very quickly and diuresed and turns around, you're never going to be in the shock paradigm. But on the other hand, if this doesn't get better, then he's going to be in a different direction. And the idea of when we institute support has to be based upon this premise that we're assessing the patients frequently and we're trying to see what their trajectory is. And as we start piecing together the time points, then we can figure out what to do. So what happens in this case is he deteriorates, he has more respiratory distress, he now has ST elevations, troponins are on the rise, and he comes to the cardiac cath lab. I'll show you the angiography, which demonstrates multivessel disease. There's slowish flow globally, but there's not one clear culprit vessel, if you will. It's basically, the culprit is the ventricle. The myocardium is suffering, and as a result, the end organs are about to. And so this is just his LAD and his circumflex. His, not the greatest V-gram shows that the EF isn't awful, but it's certainly not normal, and then he's got diffuse disease in the right coronary as well. And so what I would say would happen in a lot of hospitals here in the United States is the patient would be stabilized and a balloon pump would be inserted, and then surgical consultation or PCI deliberations would then ensue. And that's actually not the wrong thing to do in many of hospitals that don't have more advanced support. The reason I say this is because many people castigate the use of balloon pumps in cardiogenic shock. And there are subsets of patients, and this is an analysis we published from our Columbia experience, predominantly in chronic heart failure and shock, that show that you can get a reasonable modicum of support, but just not a lot of support in these types of scenarios. So it's not wrong to try it. It's cheap, it's ubiquitous, and that sort of thing. The question is what do you do after that? And do you escalate, and do you have the capacity to escalate or transfer the patient, or should you just put a more supportive device in up front? And what happened in this case is what happens too often here in the US, and what we see here is the patient gets the balloon pump, goes to the unit, pressures are escalated, echo is done, deliberations are made, and then 4 days later, because the patient's not turning around, we get the call, can you do something with this patient? And I call this balloon pump inertia. Basically, you put the patient vented, pressures, IBP, you put lines in, you CVVH, and then you wait and see what happens. And in the current era, that's just not acceptable because we do have other options for these patients. And this emphasizes this point of you need to have a dynamic system with dynamic caregivers to deal with what is a dynamic disease. This patient came in one way, they've changed, and can we adapt to that? So the way we do it in our institution to simplify things is we have a team. And the team has various inputs, all of whom have strengths and weaknesses. And so, this is the heart failure colleague says, the patient's too sick to transfer, but he could be a candidate. We have a bed, so let's transfer. Lots of deliberation on either side. The coronary interventionalist says, we need to look at the coronaries, the impella is okay, and that's what I'm fixated upon. And the surgeon says, we can send our ECMO team for assessment and transfer, and he sends his ECMO team, which is his junior fellow colleague. So that's kind of how we work, but the reality is that these three different inputs, and in other cases intensivists as well, really enable us to look at these patients dynamically and adapt what happens. This is often how we do it in our institution. They're anonymized group texts, lots of conversation back and forth to pick the right therapy for the right patient in that way. What happened when this patient came over is we put a swan in immediately and noticed several things. One is the filling pressures weren't so bad, the PA sat was relatively preserved, and the blood pressure on pressors was 200 over 110. Okay, so then you can start doing other things. We weaned the pressors, we discussed what the revascularization strategy was, and then we opted for complete revascularization. So to revascularize all three territories in somebody with shock, I think the data is nicely supportive of using more support than less support in that scenario. Why? Because in randomized trials, when you take patients like this and you revascularize them, you make them worse before you make them better because you're making them ischemic when you're doing your PCI. And at least in PROTECT 2, for me, one of the most compelling facts of the trial was the fact that the decline in cardiac output, or the decline in cardiac power output, was less with a more supportive device, the Impella, than a balloon pump. And so similarly, if you're doing more extensive revascularization, you need more supportive devices. In the same trial, if you have a limited revascularization, balloon pump may be fine. fine. But in this case, you're opting for complete revascularization. And so that's exactly what we did. We put the device in, the Impella in, and did a full revascularization of the LAD, the circumflex, as well as the right coronary artery. And then this patient, you needed to manage them for several days to weeks afterwards, and the patient did fine and left the hospital. But the idea here is things change with the patient, and we need to adapt to what we need to give based upon how the patient's changing. This is another case of a patient who really only had one vein graft supplying his whole heart. During the diagnostic angio, clot went down the graft, and the patient promptly arrested in the cath lab. VF, no blood pressure, full-blown arrest. Many interventionalists in this scenario fixate on the coronary and they want to open the artery. That's not what this patient needs. The patient needs support, and then you fix the coronary afterwards. And so this was a perfect candidate for a patient to be put on ECMO. So we put this patient on VA ECMO at the time. To differentiate it, VV ECMO, often seen in the ICUs, and we do that as well, is for oxygenation only. VA is for support. The downside of that support, though, is that you have a typically 15 or bigger French cannula in the arterial system, so you typically need distal perfusion. Patients require lots of transfusions, but it is life-saving in these types of circumstances. And in this case, it was the only way that we were able to do the intervention, which required a guide liner all the way down the graft with then a delivery of a stent in this way to supply the heart. So without that, without putting the patient on full support, there's no way this intervention would have been done, and then this patient had a good outcome in the end. There has been a shift, and Navin alluded to this, in the use of MCS. This is a review paper in JACC showing that basically in the old days we would wait for the patient to crash and then institute support. What we've tried doing now is to prevent that from happening by instituting support at earlier and earlier time periods. Now, there are downsides to doing that, but the upside is we can potentially salvage the heart. This is adapted again from Navin, who really honestly, the reason I use his slides is because he's led the field, and I think I've learned a lot from listening to him talk, and so hopefully you all will learn the same. But basically, this slide also shows you that it's not that one device is terrible and the other ones are good. It's that certain devices can be used for certain indications. And you need to diagnose the patient first to then decide which approach to use, and in some cases, you're using multiple devices as well. I want to really caution everybody to be cognizant of the bleeding complications associated with these devices. These are not trivial. There's a lot of transfusions, and this is the data we published in JAMA Cardiology showing that hematomas, transfusions, and even vascular interventions are very important. We saved a patient last week by putting the patient on first RP Impella, then transitioned over to VA ECMO, now transitioned over to VV ECMO. I had to stent the iliac with a covered stent in the interim. These are cases you invest heavily in, and you really have to go the whole hog to be able to sort it out. Final word, don't forget the right ventricle, because this is all left ventricular support. RV is also very important. This is a patient that we treated, had a 51-year-old inferior MI, reperfused and did fine. We left the swan in. These are the hemodynamics, pre-PCI, post-PCI, things are looking good, her sats are fine, but she's on a little bit of dopamine. Post-PCI day 1, the RA pressure goes up to 20, the wedge is still 16, the PA sat is down to 28. If you put a left side support device in this patient, you're going to do nothing for the patient. Perhaps if you put them on VA ECMO, you'll unload the RV, but basically in this particular case, you diagnose shock from right ventricular failure and you put in a right side support device, either an Impella RP, Protect Duo, or some other configuration through a Centromag. But immediately after doing this, goes to anuric, starts urinating, ionotropes are decreased, and then immediate hemodynamics show benefit, and then this device is weaned and the patient leaves the hospital. So I think just to conclude, the increased awareness of percutaneous options may improve outcomes in GCS. And why do I say may and not does? Because we don't have definitive proof of it. We certainly all operate under this paradigm because we don't just want to give up on patients, but it is important to generate the data, and that's being done. I do think that appropriate management cannot be super simplified and does take a team-based and patient-oriented approach, carefully weighing both immediate and longer-term goals along with the benefits not only of percutaneous support, but even durable support, because some patients are not going to be candidates for that, and that may change your upfront options of what you do. I think balloon pumps can have a stabilizing role, but it's stabilizing only, and frankly, for more supportive cases, more sick cases, you need more aggressive support in those cases, and typically, especially for interventionalists, percutaneous options tend to be the best approach. I do think ECMO works, and it's good for total crash and burns, but remember about the vascular complications, the transfusion requirements, and beyond. And then finally, the availability of percutaneous RV support has further expanded our options in armamentarium, and you need to be very familiar with that as well. Thanks so much.
So we have a few minutes for questions. Is there any questions from the audience?
Hi, Burke from Minneapolis. Outstanding talk and coverage of a very complex subject. It seems to me that the vast majority of the problems is our inability to recognize the shock before it becomes a critical issue. And does that mean, you know, every patient that hits the ED with chest pain gets troponins, EKG? Should they get a lactate? Should they get a venous pH? Do we need to change our algorithms?
You want to take that?
Yeah, I think, you know, there's enough other extraneous tests that get added to every patient that adding a lactate is a very reasonable thing to do. A lot of rapid response teams will do that and do assessments in that way. There's going to be a false positive rate, and we've certainly been called to put in mechanical circulatory support. You bring the patient downstairs, you do a right heart cath, and you know, they're hypovolemic or they're GI bleeding. But that's okay. We made a diagnosis, and it wasn't being made before. So I do think that those basic triaging steps need to happen, and there also needs to be follow through on what do you do when you actually detect the positivity to then, you know, not overtreat people, but yet actuate a plan.
Another thing, too, that came up in a meeting last night, and I thought I saw Dr. O'Neill here, but he alluded to checking an EDP before he even shoots the coronaries in acute cases as another step. And I don't know if that's something people routinely do, if that's uncommon, but I think that's another piece of data upstream that may say, you know, you get an EDP of 20 that, okay, you move along, but then that's when you also activate more of a shock process, maybe another way to approach it.
I mean, I think that's a good idea, and we'll talk a little bit later about the competing interests of door-to-balloon versus door-to-unloading, but this is where we get into a situation where there's a culture, but there's also a desire to open the artery very quickly. But also, I think in the ER, you know, we have to figure out how to better assess these. Clearly, we can't just smell it. We can't just smell shock coming. Maybe some people better than others, but we probably had to put in some types of protocols to catch these ahead of time. And then there's a resistance. These devices are still difficult. They still add a whole complexity in terms of how long the patients are in the hospital, the potential complications, vascular and otherwise. So there's an inherent resistance and a sense that maybe we can get away with some of these things without it. And so I think we have to sort of overcome that hurdle, I think.
Yeah, just to add a couple of things to this great interchange. When we identify these cases and present them at the conference, it becomes kind of clear for every single case what was missed to a way that actually should be very simplistic. When you're evaluating these cases prospectively, it's totally unclear because for various reasons, actually quite practical. One is these devices can go in but they cannot really exchange them easily one another. Let's say you have a patient on a balloon pump, you want to upgrade. It's not extremely easy to take it out and put it in. Maybe that's easiest. You have a patient on an impeller, you want to upgrade to a higher level impeller. Well, you have to use another groin. It doesn't come out over the wire easily and all that. Similarly, you want to go on an ECMO. It is not, again, a very easy escalation. Let's say you want to do a PCI and then you want to go for an LVAD. Then the surgeon is going to be upset, the patient's on Brilinta or Plavix or something like that, how they're going to do their LVAD implantation with all of that. So the strategy becomes, in the end, very, 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 very important. And we wish we had something like a STEM EKG. And again, you see how many things we miss, even with a very simple STEM EKG, the way from what we're discussing now. So unless we kind of figure out the best way to kind of triage cases up front, but take under account all the possibilities. You cannot just put something that requires anticoagulation and later on, maybe an hour later, realize, oh, this was primarily a bleeding-related event. That's an embarrassment. So all those are really conflicting with each other. Whereas with STEMI and non-STEMI area, even if it wasn't a non-STEMI, at least we knew it was some kind of a STEMI. Over here, we have so many conflicting things, and also with aging populations we all face these days, access is becoming also a significant consideration. It's like, sure, I know I want to use that, but our 80 plus patient or 70 plus patient is really not a candidate for that for various other reasons, or you try and you end up in a complication. So there's a lot of, the pathway is very complex, much more complex, and unless we start from the very beginning, and we obviously we're going to have to make some mistakes along the line and then correct ourselves, is not going to go anywhere. But I think we're more, concerned of the complexity. That's why we're a little bit lost in that complexity for right now.
Okay. With that, I'll ask Navin Kapur to come up.